2 years ago, I was doing a master's project, and I was talking with my advisor, and we decided to do a project kind of based on some of the data he'd already collected. And so I decided to look into blood product transfusion in the emergency department, and we ended up publishing it. So our title was Blood Product Transfusion Emergency Departments, a case control study of practice patterns and impact on outcome. I have no financial disclosures, but I would like some eventually. So when we started looking at a topic, I kind of noticed that there's not that much data on transfusion practices in the emergency department. We have a lot of good data in the ICU, all the way back in 1999 with the TRIC trial, and then we've kind of been using that in the ED without really looking at it in ED-specific populations. So I had a large data set of patients that were admitted for the ED who had gotten transfusions and decided to look at those ones to see who got transfused versus who didn't, and then how that affected their care. And my PI, his area of expertise was ARDS. He was doing some projects on lung protective ventilation. So we kind of looked more on the respiratory outcomes with blood transfusions. So some of the consequences of transfusions that we all have heard about is trolley, taco, hemolytic reactions. You can have allergies, infections, and embolisms. We don't really talk about this quite as much, and there's really not great clinical data about in the emergency department, but generally we've decided that you'll transfuse with a hemoglobin level less than 7 basically from the TRIC trial and from after that. So basically taking this large data set, I had to decide how I was going to look into this. So I did a case control study, and my primary outcome was looking at acute respiratory failure, need for ICU admission, or development of ARDS within 3 days, kind of looking at trolley. And there's a phenomenon of the first 72 hours that you can have like a delayed trolley or ARDS effect from blood transfusions. And previous literature has shown the rate about 2 to 10% in all transfusions. The problem with that is that I had over 2,000 patients initially to look through, and I had very limited data. So ideally, the way you would do a cohort study would be propensity matching. Unfortunately, I didn't have all the data I'd want to, and to go from by hand and get all the data and all 2,000 of those patients first wasn't realistic. So basically what I had was their diagnosis, their initial hemoglobin level, their age, their gender, and if they got a transfusion to ED. So I matched them personally 1-to-1 with that, which took forever. So that's initially how we did it. So the first results. So I had 204 patients matched to that got transfused in the ED versus 204 who didn't get transfused in the ED. The initial group, there's similar patient characteristics except in the rates of ICU admission, their initial INR, if they had cirrhosis, their initial lactate, if they got central line, or if they got how much IV fluids they got. Interestingly, the patients who got transfused in the ED were sicker. Of all the transfusions, 60% of these people got red blood cells, 31% got FFP, and about 25% got platelets. One thing that was interesting is that the controls, the patients who did not get transfused in ED, had a higher transfusion rate once they got admitted. Of the primary outcome, a combined outcome of respiratory failure, ICU admission, and ARDS, it was actually the same in both groups. So there was no difference in mortality either. So there's actually no difference, which I thought was kind of interesting considering that the cases were sicker. So our variables we kind of looked at was who got the red blood cells, FFP, and platelets, and the indications. Primary indications is mostly GI bleeding for blood products. And then interestingly, I'll talk a little bit later about platelets. The second largest indication was neurologic injury, which is mostly intracranial bleed. Of our primary outcomes, there was really no difference between in either group with the combined endpoints, which we kind of talked about earlier. So first off, I think case control studies, cohort studies, they really I think the way you can use them is they can help guide, they can be hypothesis generating for another trial. And they can also inform you on your actual on your practice patterns in this emergency department. Anything after that, there's some question as to how valid it is. So basically looking at practice patterns, there was a large number of patients who got transfused in the ED that probably didn't meet the guidelines that we had discussed earlier. And then the one thing I thought was interesting is that 24% of all patients that got transfused platelets due to neurologic injury, they had a platelet count of 197,000. And so some more recent data has been showing that the patch trial, that this might not be beneficial. So looking at this, I thought the interesting things was that the transfusion ED probably was safer than previously described, as there was no difference. Getting transfused in the ED might actually mitigate further organ failure, leading to this similar outcomes. And yeah, thank you. So I'd like to thank Dr. Fuller, who was my PI at Washington University in St. Louis, as well as everyone else who worked on the project with me, and then Dr. Hobson and everybody here for letting me talk. I'm new to the technology, and so I just joined Twitter. And so if you want to tweet me, you can tweet me. All right, thank you. Do you have any questions?
Questions, Dr. Beyer?
So Alex, I'm curious, so I'm assuming that the people with a neurological injury that got platelet transfusions were people who had intracranial hemorrhages who had been taking antiplatelet agents, right? For the most part, was that the rationale?
So it's hard to tell since this is retrospective, but it seems so from looking at all of the data from mine, all those patients. Yeah.
Great, other questions? So I'll say you can't say that you're not good at public speaking. So you got to take that right off your repertoire. So that was really great. Thanks so much for your time. Are you presenting at any of the spring conferences this year?
SAM.
Wonderful. So great. Thanks so much.